Welcome to the second annual California Urgent Care Association Fall Conference. I'm very excited to be here with you all today for a day filled with learning and virtual fun. Firstly, I would like to thank my fellow board members, Tiffany Riguera, Dr. Roger Hicks, Dr. Scott Pricey, Dr. Armando Samaniego, and Brett Walls for dedicating countless hours in the last few months to make this event possible. As you know, we are a very young organization and everyone does this on a volunteer basis and out of passion. So I truly thank you and it is my pleasure to work alongside all of you. I would also like to thank our generous sponsors, Salt Health, Xperity, Braid, Rapid Rad, Quidel, MedTrainer, Midland General Contractors, Fetch Medical Billing, and 3N Marketing for making this event possible. Lastly, I would like to thank UCA leadership, especially CEO Lou Ellen Horwitz and her team, Jackie Stash and Nicole Iwinski, who have provided continuous support to make this event happen. 2020 has been a uniquely difficult year. We have had to implement a new way of life to keep our families safe and work extra hard to support our loved ones. Many of us have faced unbearable losses, and all of us are left wondering when the time will come that this so-called new normal is over. On top of these personal challenges, fighting the COVID-19 pandemic has directly relied on all of us working in healthcare and specifically those of us in the urgent care industry. In one way or another, we have all been fighting on the front lines to serve our communities, whether it's through providing COVID-19 testing and care or making adjustments to our operations to keep our clinics safe for all patients and employees and be able to remain open. As an urgent care operator myself, I have dealt with unique challenges, from drops in the number of patients and staffing changes to constantly evolving safety protocols and testing processes. Our communities are better off because of our dedication and sacrifice, but it is no question that this work can take a strong emotional and physical toll. So I thank you for your service and for your continued strength and dedication to providing quality healthcare to your communities during this unusually difficult time. You are all true heroes, and I am absolutely honored to be in your company. Our goal with today's event is to provide you, our fellow California urgent care professionals, a space for education and community building. We will be hearing from panels of amazing industry experts that we hope will bring you practical information that is applicable to your daily practices. We will end the conference with a fun social event. I strongly encourage you to stay till the end to be eligible for the Apple Watch or AirPod Pro giveaway. Once again, thank you so much for being here today, and I hope you enjoy the program. And with that, I would like to introduce Urgent Care Association of America, Lou Ellen Horwitz.
Thanks so much. It's great to be here today and hang out with a bunch of urgent care people, which is one of my favorite things to do. 2020 has been such a never-ending crucible for all of us, in California especially. It's just really nice to take a short pause and come together. So thanks for having me. When I think about CalUCA and UCA, I feel like we both had the same reason for being, which is to try to make sure that urgent care is able to fulfill its rightful place in the healthcare ecosystem. I've been doing this for almost 15 years, and it's been a fight really the whole way. In urgent care's infancy, we were really fighting for patient understanding of what we did and our value to them. And that one didn't take very long, which was great. But then in our sort of toddler years, if you think about them that way, we were fighting for respect in the House of Medicine as a specialty, and in the association world as being a real association with payers for specialized codes and so on. Then we kind of hit our junior high, and either you were the popular kid with lots of attention and private equity money rolling in, or you were starting to feel like no one would ever ask you to the dance. There's a lot of consolidation going on. People were talking about exit strategies in an industry that was barely 25 years old. It was really a strange time. In many ways, it was the classic story of too much, too fast, or not enough, and the challenges that that brings. And I feel like we've been lurching through that adolescence part of our industry for really about the past decade. And then COVID hit. I think that's really going to be a catchphrase that we'll look back on as this parentheses in urgent cares and really in the world's history that has forced us all to scramble, but also I think to pause in some ways and make some critical decisions that we'll look back on as really important as a pivot point in the trajectory of urgent care, which to me is really exciting because it's already clear seeing a lot of the things I'm going to tell you about that we're pivoting in a direction that's going to ensure our long-term success as part of the healthcare ecosystem that was frankly starting to look a little bit sketchy there for a while. So how are we thinking about that at UCA, and what have we been doing since March, and how does this relate to our affiliation with CalUCA, and where is all of this going from our perspective? We've spent a lot of time thinking about what we are doing here and what our role is in helping all of you claim your rightful place, and how UCA's work intersects with the College of Urgent Care Medicine's work, the Urgent Care Foundation's work, and the work of the chapters. We're coming to see our role as threefold. First is to really define the industry, to take a stand on what urgent care is, how it relates to other parts of the healthcare continuum, like retail clinics or primary care and emergency medicine, and to really own that space. Our second is really to create connections, to build the kind of association that pulls in everyone in urgent care so that we can truly represent the entire industry and build relationships with a variety of stakeholders so that we're all connected to the decision-making points that affect all of us. And thirdly, in there, to do a better job at facilitating member-to-member connections within our own family. And we'll talk about that a little more in a minute. CalUCA is definitely a big part of that. The third is really to foster excellence, which means setting standards for what a great urgent care looks like, providing educational programs that move us all into more consistent operations and practice, and then ultimately into quality improvement, and taking a national level thought leader role in what patient experience, quality focused healthcare can really look like, because that's what we do in urgent care and we do it better than anybody else. So this isn't really a shift for UCA, but a refocusing. Let me give you a couple of examples. Let's start with advocacy. In the past 2 months, I think we have had more meetings with more influencers of policy and regulation and payment systems than we had in our first decade. And many of these groups I've never heard of, which actually tells me that we're on the right track, that we're finally starting to get inside versus just on the fringes. We have a meeting with one group that'll lead to a connection with a related group, all wanting us to educate them on the role that urgent care has been playing in COVID. The traction that we're getting is really unprecedented. It's super exciting to see. One example of this is coming up in 2 weeks, 10 days, on October 27th. The Deputy Director of the CDC's Vaccine Task Force is doing a virtual town hall meeting for UCA's entire membership, courtesy of the College of Urgent Care Medicine. A year ago, that would have been impossible for us to do. So thank you for all of the work that you've been doing. It's making them take notice in a way that they never have before. I think that it's due to a couple of things. First is the work that you're all doing, the work that UCA has been doing for years, finally paying off, but also to a phenomenon that COVID has created in other industries outside of urgent care, making their culture begin to mirror ours more, when in the past we really were trying to fit into theirs. They've had to become open-minded and nimble and creative in ways that they weren't before, but that's just our daily bread. And so when we're having these meetings, it's really been delightful to see how excited they get with our can-do attitude that we've brought to fighting the pandemic and just the way that we are. I think it's refreshing for them and has helped move things forward a lot. CalUCA has an opportunity with this as well. The Urgent Care Association Political Action Committee, the national PAC, has been in existence for a few years, but there's not been much activity in California. And so I'm guessing there are influencers whose attention you're not getting on the more localized level. So we've made the decision to transfer ownership of the California PAC to CalUCA going forward. And so I'm hoping this will help rally all of the members in the state to be able to support the initiatives quickly when you need to get the attention that you deserve. We're also investing in some software that will make that grassroots advocacy really easy for everybody. So that'll be much simpler than it's been in the past, and we're excited about that as well. I want to give you also an example of the member connection strategies that most of you have probably been part of, and that is the COVID listserv. For years, we've known that members wanted to talk to each other on an ongoing basis to share information and problem solve and so on, but we've never really been able to make that happen. And I think lately it's partly been due to an unwillingness to share information the way that we used to in our scrappy early days, but COVID changed all of that back. And when the College of Urgent Care Medicine's COVID task force opened those communication lines to the membership via the listserv, it was flooded, and we've had some great innovations come out of that group. We're once again sort of making it all up together, and that's been very refreshing. We want to see that continue, and we can do way more than the listserv. So while we're going to keep the listservs going, we are going to start taking advantage of the biggest connection platform out there that there is and create some member-only groups on Facebook. CalUCA is going to be part of launching this, going to be the leader in launching this today, actually. It's ready right now for you to be part of it. I think we might have a screenshot, but if you don't have a face, there you go. It's already set up and ready to go. If you're not already on Facebook and don't have an account, they are free. You can ignore all the rest of Facebook if you want to, so don't be intimidated by that if you aren't already out there. Just search for CalUCA in the groups, and this community will be restricted just to CalUCA members. You have to apply to be part of it. We'll approve you. And it gives you a protected place to talk about whatever issues are important to you, stay connected to each other across that big old state. Quickly respond together to something that comes up that needs attention or that you begin to get a whisper of, particularly legislatively. That can be really helpful. And just have a place to hang out with your people when you need that on a hard day, or to share something great when you've had a fantastic day. So we're very excited about that and hope that you enjoy using it. I want to close with expressing how much UCA values its affiliation with CalUCA. While we can define the industry and create connections and foster excellence at the national level, right here on the ground locally is where the real action happens. We've been talking lately with the CalUCA board about how we can do more with the West Coast as a whole. I'm in Washington, perhaps bringing in other states. We've done that with NARUCA in the Northeast. So there are lots of things on the horizon, as well as some new UCA member benefits that we'll be announcing soon. Sometimes I think about UCA kind of like NASA and all of our members, all of you as the astronauts. We can do all of the training and lay the groundwork and set up mission control, but you guys have to ride the rockets. And we are just so thankful for the partnership that not only brings all of you together in your state, but that makes you part of us. I'm really glad to be here today and so appreciative for all that you're doing every day in your communities, but mostly for the kind of people that you are that brought you into urgent care in the first place. So thanks again for letting me be part of today. I'm really looking forward to it.
We will begin the CME portion of our program.
Good morning, everybody. My name is Roger Hicks. It's my pleasure to moderate the leadoff panel here on our second annual California Urgent Care Association conference. I hope that this panel is very thought-provoking and informative for you. We have some great panelists, and we're going to be talking about how the pandemic has impacted healthcare in the U.S. from private practices to healthcare systems to public health. We're going to discuss some short-term and potential long-term impacts of the pandemic on urgent care practices, hospitals, healthcare systems, and public health and our public health institutions. And our goal is to enable you all to better adapt and to help improve our new reality. So it is my honor to introduce our panelists. Actually, Llewellyn Horwitz, you've heard from just now. I've known Llewellyn for many years. I met her at my first Urgent Care Association conference at South Lake Tahoe. She is, of course, the CEO of the Urgent Care Association. Prior to that, she was the Director of Organizational Development for the Retail Health and Community-Based Care Division at MultiCare in Washington State. That consisted of 45 urgent care centers and also included occupational medicine, virtual health, pharmacy, lab, imaging, home health, and hospice services. Prior to being acquired by MultiCare, Llewellyn served in a similar role at Immediate Clinic, which had 17 urgent care clinics in the Seattle area. Llewellyn was the original executive director of the Urgent Care Association of America, and that's when I met her back in 2007, I believe. And she served as a member of the Urgent Care Association Board of Directors from 2016 to 2020. She's had an active consulting practice on the side, and she has a master's in organizational management and did her undergraduate work at Vanderbilt. I'm really happy to have my colleague and friend, Dr. Brian Evans, on the panel. Dr. Evans practiced in the emergency department at Sierra Nevada Memorial Hospital here in Grass Valley for over 20 years. He was made Chief Medical Officer of Sierra Nevada Memorial Hospital in 2018 and named Chief Executive Officer in December of 2018. In his role as Chief Executive Officer of the hospital, Dr. Evans has primary responsibility for the quality of care, of course, but also for patient experience, physician performance, and financial stewardship of this community hospital in a rural area. A California native, Dr. Evans went to UC Davis, and he lives here in the community in Nevada City with his wife, Jennifer. And our third panelist is Dr. George Rutherford. Dr. Rutherford is the Salvatore Pablo Lucia Professor of Epidemiology, Preventive Medicine, Pediatrics, and History, and head of the Division of Infectious Disease and Global Epidemiology in the Department of Epidemiology and Biostatistics at the University of California, San Francisco. He serves as an advisor to the CDC and to the World Health Organization, and has been involved in the public health response to the COVID epidemic since the early days of the pandemic. So I think I would like to start with you, Dr. Rutherford. As a public health and infectious disease expert, what are the top 2 or 3 concerns that you have at this time relating to the pandemic?
I think, sorry, I think that thank you very much for having me. It's a real treat. My wife ran the emergency department at Oakland Children's for 30 years. So I know, I know to whom I'm speaking here. I think the biggest concerns right now that I have are around vaccine acceptance. How many people are we going to manage to get vaccinated? How much pushback is there going to be? Can we really get to a point where we can protect the population without having to keep wearing masks and shutting things down all the time and doing all the kinds of more draconian public health measures that have been required? If you say that the level of herd immunity required to stop transmission is around 70%, and it may actually be a little higher than that. If you have a 90% effective vaccine, that means you have to vaccinate 77% of the people in order to stop transmission. That is not going to happen in this state, I can tell you that. And I think we might be lucky to vaccinate half. But so if you have the opportunity to encourage people to be vaccinated, I think that's a huge, big thing. There's a tremendous, that's one big challenge. The other challenge is there's an exceptional amount of misinformation and frank disinformation that's circulating. And I spend at least half of my time dealing with sort of unfortunate things that have gotten to the media, and to try and tamp things down and get them back into the box. This past week has been the White House task force statement about herd immunity, which is just, you know, it would be 100,000 deaths in California. So it's just not, you know, there's all sorts of crazy stuff that goes on, and trying to get things put back into the box and keeping us on an even keel is one of my major challenges, and one of the things I see as a challenge for all physicians and healthcare workers around the state.
Mm-hmm. Great, thank you. Dr. Evans, you're the CEO of a community hospital in a rural area. What are the three most important ways the pandemic has affected community hospitals? And sort of corollary, are the effects different in rural hospitals than they are in urban hospitals?
Well, thanks, Roger. I appreciate being here. I always think things are different in rural hospitals, and actually really like the comment from Llewellyn about not getting invited to the dance, because I think that we in rural community hospitals often feel like we're the ones not getting invited to the dance. I would say the COVID pandemic has been an exacerbation of some longstanding issues that affect rural community hospitals and have done so for a long time. And you guys probably all know that rural community hospitals are sort of under threat of closure all the time. We're sort of all running at a very minimal operating margin in most cases. There's been over 100 community hospitals closed in rural areas over the last decade across the United States. The operating margin for these places is typically 0.5%, and that's gone down as a result of the pandemic. So I guess the first thing I would say is financially, it's been a big challenge for us. We're not alone in that. But what we saw initially with the pandemic is an immediate drop off of elective surgeries, ER visits, and hospital census. And for anybody that knows anything about a rural community hospital, and most of them are functioning on a fee-for-service basis, that's just devastating to your bottom line, because you cannot reduce your cost structure proportionally when that happens. It just doesn't happen. So, we immediately started posting huge operating margin shortfalls every month as soon as the pandemic hit us. And of course, that resulted in CARES funding being enacted for hospitals across the country. And there was specific funding for rural community hospitals like ours, which is good. But it actually has not covered the gap fully for most of us, unfortunately. So financial would probably be the number one thing. I would also say that psychologically, it's been really challenging for healthcare workers in hospitals. And I don't think it's just us. I mean, I think it's all over the place. And I certainly think it's including folks in urgent cares and urban areas as well. But it has really been a long grind, and I think everybody is stressed, and it's not just their job at the hospital, but everybody I know has stresses related to the pandemic economically, with spouses or with kids or with remote learning. And everybody wants to know, when is this going to end? So Dr. Rutherford's comments, I think earlier, worry me, frankly, because everybody wants to know, when are we going to get to herd immunity? When are we going to be able to go back to business as usual? When can I open up my pizza parlor again, or whatever it is? And that psychological damage is problematic. So, we're trying to figure out how to mitigate that for our people and their families here at the hospital, but it's a team sport. The other thing I would just say, I think I would be remiss to not mention that there has been an opportunity here. Now, no one would want a pandemic to come along to create an opportunity for your business to improve or to transform it. But this has been an opportunity for people in our community to understand the value of this hospital. And it's been an opportunity for them to rally around us and for us to serve them in a different way. So that has been one silver lining of this whole thing. We've been able to really connect to a lot of other healthcare leaders in the community, including yourself, Dr. Hicks. And I think that's been very, very positive for us. We've been a lot more deliberate about communicating almost every day through every media channel we have, including social, in a way that we just didn't do before. And we're being listened to because people want information from healthcare professionals. They're getting a whole bunch of information from the politicians that is really all over the place. And so they're wanting to get some information that is accurate, timely, and it's sort of not, politicized, essentially. So I think that's been a good thing. And I think our employees are very appreciative. Our physicians are appreciative of their, sort of enhanced status or the way that people are viewing them in the community they didn't before. So.
Great. Yeah. Well, along those lines, the hospital here has been very supportive of the physician community, and we have had a Friday morning call with the community physicians and the hospital every Friday morning at 7 a.m. since the beginning of the pandemic, basically, which has been, I think, really helpful. And I've had more connection with the hospital and with other physicians in the community since the pandemic than ever before, really. So, yeah. Llewellyn, so you are the CEO of the National Urgent Care Association and get a lot of information coming to you and to your staff about what's going on in the urgent care industry. What are the 2 or 3 ways that COVID has affected the urgent care industry that had the most impact, or the most profound things that you've seen?
I'm glad Brian went ahead and brought up psychology early on, because I think that that's had a lot to do with this. I think early on, we realized that no one was coming to help us. And, that's part of us not being, tied into the national fabric the way we're getting better at now. But I think we realized that we had to help ourselves, and had to help each other. And I think that was a profound culture shift for urgent care, that it was almost a throwback, as I said a little bit earlier, but it's time to lower all the barriers that we had about, we're competitors and those kind of things, and go right back to the basics of what are we doing here, and let's come together and figure this out. I think, the first couple of weeks of March, really all of March and going into April. I think, in fact, we have a graph on this. I'm not sure if we can pull that up, but the graphic of what, there you go, happened in urgent care visits, that's traumatic to look at right there. And I'm sure you can all remember what that felt like in March and April. But look at what happened after that. That to me is amazing. That up was significant, and that was urgent care doing that on its own. And that, I think, is really a profound thing to see, is how quickly we were able to jump on this once we realized it was going to be our responsibility, and there was not going to be something from on high fixing this for everybody. We had to jump in and figure it out ourselves, which is one of the things that we do best. So I love this graph. It's horrific in some ways, but dang, we figured it out. And that really encouraged me a lot. I think we sort of dug back into our entrepreneurial roots and got together and made stuff up and figured it out and got ready to serve our communities. However, that uphill was as hard as it looks. I think it was a very steep climb because of all of the challenges that we had with supplies, both from a test kit standpoint that we're still having, and not sure when that's going to ever be, steady. But just basics of PPE and all of those kind of things. I think that really, that was a very sobering period for all of us, that kind of went back to the feeling that nobody was going to come and help us, that we had to figure this out. You saw things on the listserv of people buying rain ponchos because they had no gowns. It was that level and worse, of people creating their own test kits and, out of putting, tubes and caps together themselves and really building those things to hold the medium because they just couldn't get supplies. And so I think that that has probably been one of the more profound shifts. There's fear and all those other things that we can talk about, but I think nationally, that's probably been the thing that will last the longest that's happened to us.
Okay, great, thank you. So George, back to you. What do you think the most profound impacts of the pandemic have been on our public health system? It's been in the news, you know, more than ever, and both on, you know, I've had more interaction with public health since the pandemic than ever in my 40-year career.
So that's a good thing, right? Yeah. And it's not only you, but it's the public that starts to understand about what public health is and, unfortunately, what it isn't. I think we've had, there are lots of things that have gone on. One is essentially the total abnegation of the federal role in public health. It's been a colossal mess. I've worked at CDC a lot, and it'll take a generation to fix CDC. It's been just devastated by this. I think, on the other hand, the state health department and the local health departments here in California have stepped up to the plate after a large period of initial shakeout. I don't know, people realize how many local health officers were resigned or forced out by unhappy boards of supervisors. But I think, and the Orange County health officer was actually directly threatened with crowds surrounding her house. So, you know, what the hell is going on? And it's, I think the state has taken the heat off of them and has put its own system in place. So it's absorbing the heat as it should. The other thing that I think, you know, I was going to say with the you know, public starting to understand what public health is. So in the old days, if you'd ask somebody what public health is, they'd say Los Angeles County General Hospital, right? That's what they think public health is. They think it's public health care. Yeah. Now, you know, most people know that epidemiology is not a subspecialty of dermatology, which is that's also a good thing. So I think, you know, we've gotten a lot more, obviously we've gotten a lot more visible. We've gotten a lot stronger at the state and local levels because the federal government is not doing its job. And the other thing is that I think the other downside to remember is that everybody is doing nothing else but COVID, and stuff is diverted away from other public health programs like crazy. So I haven't heard the word vaping in 6 months from a public health department. You know, we all know about mental health consequences, but, you know, don't forget that the large epidemic that was sweeping the country before all this was with opioids and opioid overdoses. You know, where did that go? What's going on with that exactly? You know, there's a lot of stuff that has dropped off the table, and it's not just acute things. It's more chronic things as well. It's sort of acute on chronic things as well. I can tell you in Germany, the proportion of juvenile diabetics who are diagnosed with DKA, and frank DKA in an ER, went up by 50% during the epidemic because people were staying away. And you all know the cardiovascular disease data, where you know, people are staying away. You know, where'd all the MIs go? You know, who knows? So those are big problems. But on the other hand, there's a lot more recognition, at least at state and local health departments. And to illustrate this, I'm the residency advisor for general preventive medicine and public health for the medical students. Okay. You know, and we have to do all these informational sessions, and I do, you know, there'd be like one person every other year that I'd see. This year, 47 showed up.
Oh my gosh.
A lot more. It's like, what are you guys thinking about? There's a lot more interest in this, and I think you'll see a generation of people who become a lot more interested in public health and you know, in the subspecialty that I do of communicable disease control.
So do you think that, this is actually a question from Brian, that one that we've wrestled with here is, has the physician community as a whole done enough to stand up for our public health officers and, you know, speak out about the harm done to our public health institutions, in your opinion?
I think so. I mean, I'm not. I think JAMA has been really, just to talk about organized medicine, I think JAMA has been really a great source of information and a great source of blowing the whistle when things, are getting out of control. I think the Lancet was kind of the preeminent British public health journal, although it's obviously clinical, but they publish a ton of public health stuff. Has been very forthright about calling problems problems. So I think at that level of organized medicine, things are people are speaking out. I think locally, yeah. I mean, haven't seen any, at least in Northern, and I deal with the Bay Area, so it's a bit of a special case, as you all know. And San Francisco is an even special case within the Bay Area. I see absolutely none of that. However, if I were in Orange County and were the president of the Orange County Medical Association, I don't know kind of what they were doing to stand up for the local health officers. So it's a good question, and as far as I can tell, it's happening, but I couldn't tell you that in all circumstances.
And you mentioned a shakeup on the state level, sort of toward the beginning of the pandemic, I think is when that occurred, right? Or a little bit into it.
Into it, yeah.
That settling out.
Yeah, well, it's the state health officer was basically fired. There was a it was not without cause, but it wasn't about her personally. It was about performance of the department. And they brought in a woman who's been the head of the health office for Alameda County. So here's somebody who actually knows public health on the ground. And she attended in pediatric infectious diseases at UCSF and Oakland Children's. So she knows clinical medicine. She knows public health from the ground up. She's a perfect choice. But we need 55 more of those people like that. And they brought back everybody who was in retirement to the state, and they've cobbled together a pretty good team. And the people, so the way the state health infrastructure is arranged is that there are a bunch of departments like healthcare services and social services and stuff that are arrayed in an agency called the Health and Human Services Agency. And the director of that, Dr. Ghali, Mark Ghali, is a pediatrician who came from Los Angeles running community clinics. And the deputy, Alice Chen, was the chief medical officer at San Francisco General. So these guys know this stuff inside out. And they've been absolutely terrific in providing cover for the health departments, for the public health department, state public health department, as well as the local public health department. So it's seldom, in my experience in the state, it's seldom got up to the level of the Health and Human Services Secretary, who's the cabinet officer.
Yeah. But it's Heidi Steinecker is the person they brought in.
Yeah, putting their finger in the dike and really making it, stopping the bleeding.
Great. Brian, Sierra Nevada Memorial, of which you're CEO, is part of Dignity Health, which is part of Common Spirit Health. Common Spirit is a large healthcare system, I think with over 1,000 sites, care sites in 21 states. So how has the pandemic affected large healthcare systems?
Well, I think it depends on the system. For us, I think it's been very revealing of some gaps. And I don't think it's unique to Common Spirit Health or Dignity. So first of all, I'll just say, if your health system is set up as a mostly fee-for-service type system, I think it was more problematic than if you were set up more like a Kaiser. So I don't work for Kaiser, but my understanding is that they did okay with this, they financially, because their cost structure and their revenue structure is completely different, and they didn't see a revenue drop off, obviously, because they're the insurer. And in many cases, their costs actually went down with the pandemic, especially initially. So, when we look at how we were affected at Common Spirit Health, it was much more problematic. But there's been a lot of other things, really important lessons, I think, with things like supply chain. So.
Brian's muted.
Oh, can you hear me now?
Yeah.
Okay. I don't know how that happened. Okay. So what we found with supply chain was, if the utilization of supplies is basically stable and the production of supplies is basically stable, everything's fine and everything is supplied in a just-in-time sort of fashion. This is probably the same way it is in urgent cares, I would think. But obviously, when you have a pandemic and all of a sudden the utilization rate goes up a little bit and maybe production goes down a little bit, you have a disaster on many, many different products that you need all the time to take care of people. So we had to figure out a way to deal with that. And what I found, because I got turned into the supply person for the whole division, was that our mechanisms were...
And the division, you mean 6 hospitals, right?
Yeah, I mean like the Sacramento division, which is 6 hospitals and all the affiliated clinics and everything. And we were not set up for this at all. I mean, it was really a lot of manual processes, not a lot of automation. We just didn't have the tools in place. And it was like, in some ways, frankly, it was like the Keystone Cops running around. And I don't think we were the only ones dealing with this kind of a situation. So, I mean, supply chain, and then the way the division itself was organized structurally with different teams of people doing different things, it was not set up for a pandemic. We weren't nimble enough. It took too long to make decisions. And so we really had to restructure our divisional organizational approach. And that's been done now. So I think we've actually gotten better as a result of the pandemic. And so we're probably more prepared now for whatever comes next. But that was really interesting to see that happen. But it also makes you realize we need to move, I think, in this country more towards a fee for value type situation, a population health management mechanism, as opposed to a fee for service, because that's going to be the way forward for this kind of a deal. The other thing I would just say is that we've seen some other things with regard to data. Our ability to extract data and quickly deal with it is not as good as it needs to be. I think some other systems are more adept with that. And then virtual. So that has been a big change for our system, is going virtual. And I'm curious if that's also been the case for urgent care too. But I mean, we went from like very minimal virtual visits being done in offices to a huge amount, and basically overnight. And so that's been, I think, good to see. Obviously, a lot of that has to do with reimbursement, but those are the big ones that I sort of saw happening with the system, and a lot of lessons learned.
Great. Well, that's a perfect segue to you, Llewellyn. What's happened with virtual visits in urgent care?
Overnight was a really good way to put it. That was one of the things that was, I think we thought we had, 4 or 5 years to ease into this, and it was more like 4 or 5 days. I think the stats within, mid-April were that 90% of urgent cares had stood up some kind of virtual visit solution. A lot of them were using them for just triage from the parking lot kind of work, versus having a, full-on replacement virtual visit. But it's been interesting too to see how that has sort of leveled off now. It went, I think the stats I saw from my friends at Multicare were that their visits increased by 700% in their virtual. And so, and we got that same kind of data from Xperity, but patients still want to be seen. And so I think that's, there was a little bit of a fear factor there of, okay, everybody's adopted telemedicine, urgent care is over, everybody pack up and go home. But that's not turned out to be the case. But I think it's a huge opportunity for urgent care to be in that space, because what we have with urgent care and telemedicine that telehealth doesn't have on its own, and some of the bigger platforms, is that warm handoff to an in-person visit when you need one. And so I think that's really something that is being worked on now, is how to really weave that into your total practice approach, not just as a quick fix for COVID or necessarily as just a load balancing tool, the way that some folks have been using it. So it really allows you to have this continuum of care with your patients that can be very responsive to what they need, particularly if we can get the reimbursement laws to stick. So it was interesting to see.
Great. And what are other things that are, facing urgent care practitioners right now? A couple of other big things.
Yeah, I think it's mostly connected to uncertainty right now. And to echo some of the things that George was bringing up, that really uncomfortable knowledge that the people that are making the decisions right now don't understand us. And so they are accidentally making decisions that are wrong just out of ignorance. And that makes it very hard for urgent cares to plan for the future. When we look at the vaccine administration opportunity, do we or don't we? We don't have enough information. And so that's one of the things we've been really trying to get ahead of, like we weren't able to get ahead of this with the CDC and others, is let us tell you our capabilities and let us get that seat at the table. And this is really important, most important at the state level. There's only a small percentage of what's going to be happening with the vaccine that's happening federally. There are multiple tiers of that, and you can learn all about that on the town hall meeting on the 27th. But the vast majority of that decision making is being made at the state level. There are task forces that have been set up, and so getting in on those conversations early is critical so that you have the opportunity to participate in the right way. But I think the overall concern and the conflict that a lot of urgent care providers are having right now is that we want to be part of it, but we can't go out of business being part of it. And so it's really a matter of what's that going to look like from a reimbursement standpoint, from a reporting standpoint, all of those things so that we can participate without it ruining us financially. So that's really what's top of mind right now.
Yeah, that's echoes what Brian was saying. I mean, it comes down to no money, no mission.
And Roger, you know, I actually got asked a question in the chat privately about why we should move towards value as opposed to fee for service. So I can expand on that a little bit if I have time, but I'm sure I'm not the only one who has thoughts on that. Essentially, you know, we're in a situation like most rural hospitals where the margin comes from elective surgery more than anything else, elective cases, and specifically commercially insured lives, not government, because we lose money typically on everything in Medicare and Medi-Cal, not everything, but most things. And on balance, they're not helpful payers. So we're really cost shifting towards commercial insured patients, just like every other hospital that's in a fee-for-service world. So if you go back in time, it became very clear that the growth of revenue over time was at a certain rate, but the cost was going up at a much higher rate. And so at some point, the paths have crossed. They've already crossed for us. We're operating at a negative operating margin here at Sierra Nevada, and I think many rural hospitals are doing the same thing. So it's really just a waiting game to see how long it takes for everybody to run out of their cash on hand. Many hospitals are, you know, less than 90 days of cash on hand. So we're fortunately better than that. But that's basically the situation we're in. We have to figure out a way to move into a different financial model where our incentives are aligned with the community, where the community is trying to keep people healthy, people get the care they need in the least expensive manner possible and in a way that actually promotes their health. Instead of our incentives being about doing surgery on people as much as possible and growing those service lines and bringing in surgeons and doing that sort of thing. We want to keep the community healthy. That's the goal ultimately, and that's our mission. But our financial incentives are not aligned with that mission typically through a fee-for-service mechanism.
Right.
And that value,
go ahead.
Reimbursed appropriately. That's you know, we're sort of in that situation if you look at global contracts in urgent care. And that's what's killed us. As you say, that line crossed when all of a sudden our supply costs weren't $7 a test, they were $45 a test. You can't make that model work if there's not some level of control over the supply chain costs. Completely agree.
Yeah. So George, when do you think, I know this is pure speculation, but when do you think a vaccine will be available to the general public?
I think we'll have a vaccine in about 4 weeks, honestly. But it's going to be very restricted use. Remember, these are all 2-dose schedules. So when you hear they have 100 million doses, that means they have enough for 50 million people. And the distribution, as you will find out in your webinar, is brutal. It requires, for the mRNA vaccines, it requires -70-degree refrigeration. Right.
Oh, so, we have one of those.
Oh yeah, everybody has one of those in their house.
Yeah. Uh-huh.
But that's, you know, that's kind of the first tier of people who are going to get it, are going to be mostly ICU people and emergency department and urgent care and people who are actually going to come into contact with real patients. Maybe some of the contact tracers will get it as well. And then, and hopefully most important of all are the attendants at long-term care facilities. After we go through that, and there's some other federal things that are going to cut off the top. So the Navy's had a horrible problem with COVID and outbreaks on ships and things like that. We need to put an aircraft carrier in bed for a month. You know, that's not great for national defense. But so that's going to be the first dollop. Then the second dollop will come around, I think probably around January. You know, the one of the good things about Operation Warp Speed is that the manufacturing processes have been set up in parallel. Typically, you get the vaccine approved, then you set up the manufacturing processes. So these things are all ready to go, down to fill and finish and distribution. So that's good. So that's going to happen pretty quickly. I think we're going to.
Let me just ask, the at-risk vaccine production, doesn't that mean they're actually producing them before the vaccines are approved?
Right. But they did that. They set up all the kind of the facilities first. And now that we're narrowed it, and it looks like there are three real contenders in the U.S. or four, they're starting to manufacture them. And if it doesn't work, out of money, just too bad. But but I think we'll have a fair amount available by February, March. If we have to vaccinate 40 million people in California, you know, that's 80 million doses. You know, you can do the math. And it's going to take a long time to do that. And there have to be all sorts of information systems set up because you need 2 doses and you need to know who gets it and who doesn't get it and all that kind of stuff. So I think by maybe this time next year, maybe a little earlier, hopefully a little earlier, we'll have the population about as fully immunized as we're going to be able to get it.
Okay, well, Brian and Llewellyn, Brian, I'm going to ask you first. What plans does Sierra Nevada and other community hospitals have to help with this vaccine administration? And Llewellyn, what plans are underway to have urgent cares be part of that vaccination program? So Brian, go ahead.
Yeah, I mean, we're all in to help out with vaccine administration. And also, I think, as Dr. Rutherford was saying, the educational component of this is going to be really critical to get people to have confidence in the vaccine and to be willing to take it. So I think it's both the actual mechanism to provide the vaccine, but we got to get people to show up. In Nevada County, as you know, we have a lot of people who are very much anti-vaccine in general, and that was well before this pandemic started. And now I think there's concern that there's reason to doubt, the vaccine as it comes out, and that has me worried. So I'm certainly going to be thinking about how we can use our hospital and our communication channels out to the community to get people to understand the importance of it and how that'll move us forward so that we can kind of resume normal life at some point. But yeah, we've done a number of different things with drive-through testing and all that kind of stuff. So we're happy to participate in vaccinations.
Does the hospital have a refrigerator or freezer that goes to -70?
I was actually writing that note to myself to check for later. I'm going to think we do, but I don't know.
Yeah.
Probably not in the kitchen though.
Right. I know. I don't think it's in the kitchen. No, that's like for stem cell research type of.
Yeah.
I think. Anyway, and Llewellyn, what about how are urgent cares? What's being done to enable urgent cares to be able to participate in the vaccination program? And do they even want to do that? I know you've been surveying urgent cares across the country.
Good question. First, I had a couple of requests privately for the link to the town hall. And so I've put that in the chat so people can go and register for that. It's free.
And when is that again? Can you just say a word about that?
Pardon?
Can you say a word about the town hall? Just,
Yes. Yep. The head of the CDC's vaccine task force, Dr. Rita Patel, is going to be joining us, and we'll talk about more in detail what I'm going to tell you in a second about what we've been doing. And it'll be open for questions and that kind of thing. So we're really excited to have her. She's presented a couple of times to some smaller groups. And she is a big fan of urgent care, which has been very refreshing. So again,
when is it?
October 27th, 11 Pacific.
Thanks.
So the link is in the chat for everybody. Where we've made the most progress is really in this relationship with the CDC. And there's a couple of different tiers. The first tier, as George was saying, is going to be primarily people like you all, healthcare workers, high priority groups. And though that contracting is going to be done by organizations directly with the CDC/McKesson. And so the getting to be part of that tier is very, very difficult. They're requiring a minimum of 200 sites as part of a single legal entity. And so there's very few players in urgent care that really qualify for that. But one of the things that we've been working on with them, they do still have some flexibility there, I think, based on what she said. And so we've given her a list of all the urgent cares that have 50 and above, because we think there's probably some gap filling to be done, either in rural communities, those kind of things. So that's what we've been doing on that tier 1 group. But where urgent care really comes into play is in tier 2, which is, when we start talking about the general public. And as I said earlier, that is really being managed at the state level by their existing vaccine administration offices. And so there's a whole system that exists for that already that we're probably not really tied into, since we're not, major vaccinators typically from a childhood vaccines perspective. But there was an interim playbook published to all the states by the CDC in the middle of September. 54 pages, nothing about urgent care. And so we've made some progress there. It's a living document. So we've gotten urgent care added in the section that was just about pharmacies. And so we were able to educate the CDC on our throughput. That was really, they had a couple of main concerns, because it wasn't in this case that they didn't know that we existed. It's worse. They knew that we existed and they decided not to use us actively. And so we really pushed on her with that. And she said, well, we didn't know that could you do 50 a day? And I just started laughing. It's like, yeah, we do 50 of way more complicated things than this a day. Were we capable of doing the reporting? Of course we are. And were we capable of, did we already have supply chain relationships that we could, activate, assuming all of the, the frozen storage stuff got? And yeah, we're already getting, multiple shipments a week. That's just, this is what we do. So it was, I think, really helpful. We got added into that playbook, and then we were able, she has a weekly call with all of there are 64 state and various other groups of these vaccine task force. And so we gave her a list by state of every urgent care member or not that was part of those states. And she was able to get those in the hands of those people. And so they were able to not only include them in the plans for tier 1 to make sure all those centers were able to get vaccines themselves for their staff, but also in the playbook for tier 2. So all of that was really in one phone call. And so that was great. So I think that we are much better positioned now than we were 3 weeks ago to be part of that. But making those connections on your end, we just yesterday got the list of all of those contacts in those 64 things. So we'll be pushing that out to the members so that you know who to call. So you're not just calling the Department of Health and hoping that you don't end up in a voicemail. So we'll have that information out next week for everybody so that you know who to go to and volunteer to be part of whatever is going on, at least so you have that seat at the table so you can make an informed decision of whether you do want to participate. Because Roger, you're right, we may not want to. It may turn out that this is something that we do want to leave to the drugstores and we don't want to get in this business at all because it's just too onerous. But that remains to be seen, and we need to stay part of it until we know.
Yeah, I mean, the logistics are important, and also I think the reimbursement is important.
So is the reporting. It is a daily reporting. The tracking that we have to do for the dual dose. I mean, we do that with TB every now and then, but yeah, it's significant.
Okay, well, George, I'm going to come back to something you mentioned earlier about the CDC, and I would add in there the FDA and maybe even NIH. You know, there's been damage, in my opinion, to their reputations. And then the US withdrew from the World Health Organization. So, you know, what do you think it's going to take? You said years or a generation to restore confidence, but I'm hoping that, you know, there's a quicker route to restoring public confidence and also professional confidence in those revered public health institutions. So I just wondered if you could comment on that and you know, what you think of the implications of our withdrawing from the World Health Organization are.
Well, it's criminal. I mean, there's no other word for it. And actually, but don't worry, it doesn't. You can't do it until May. So there's a chance to put the skids on it, and just pay up what we owe. We put up a third of the budget for WHO, by the way. So you can imagine how crippling these kinds of shenanigans are. So WHO we need to be part of WHO. We need to be part of world solutions. You know, I think isolationism went out in 1941 as a strategy for foreign affairs. And, you know, if we can't control, if COVID's not controlled in Mexico, it's not going to be controlled here. If it's not controlled in Canada, it's not going to be controlled here. It's not controlled in China, which it has been, by the way. It's, you know, but they're looking at it and saying, if it's not, you know, if you can't control COVID in the United States, we can't control it here in China because it's been continuously reintroduced. And as you know, Europe's on a big second wave, started a big second wave of infection. So that's I think that's kind of a general term about WHO. FDA is not, FDA is a wonderfully competent organization. It has a political leadership. It's always been a political target. It's used to being beaten up in the press and by pharma. And it's, you know, I think that'll be a lot more resilient than CDC. Although, as you may know, Governor Cuomo in New York said they would not accept a FDA emergency use authorization for a vaccine in New York State unless they independently reviewed the data. Gives you an idea of the level of trust. The Governor Newsom has not said anything like that, although, you know, you never know. You never know. I think that's really going to take that'll be a kind of regime change with some new senior leadership at FDA. The other, and then NIH actually comes out smelling like a rose, I think, as long as the Moderna vaccine, which is the NIAID's kind of vaccine, works and doesn't have a lot of side effects associated with it. I think Dr. Fauci has been one of the real heroes of the epidemic.
Right.
I don't know if people know this. He's 79 years old and goes to work every day to get beaten up by these guys, and tries to keep the country on the straight and narrow. And, you know, if anybody deserves a Presidential Medal of Freedom, it's he. CDC, which I've worked with a long time, is profoundly demoralized. CDC used to be very much above the fray. That ended in the Reagan administration. So you have to realize this has been a 30-year skid at CDC, and now it's gone over the edge of the cliff. You know, I think it's going to be difficult to recruit people to CDC. I think the laboratories are in shambles. There's a lot of internecine warfare back and forth with FDA about laboratory quality at CDC, which just should not happen. The second tier of leadership at CDC is totally competent, totally smart, but not politically adroit, because CDC is used to being sort of in Atlanta hiding out. I don't know if you know this, but CDC is physically on the Emory campus.
Right.
So it's kind of a very academic feel to it. It's separate, it's federal property, but it was given to them by Emory. And they shares a parking lot with the Emory Public Health School, just so you know kind of how the academic pretensions, but it's all true. And I really think it's going to take a generation for CDC to recover its swagger. And that has to be a big priority of the new administration, getting people in there and above them at the level of the Assistant Secretary for Health, the Surgeon General, who's actually done a pretty good job. He's not a bad guy. But the Assistant Secretary of Health and the Health and Human Services Secretary, who can shield these guys from the crazy politics of Washington.
Okay, yeah. Well, let's see. There's so many more questions I want to get to, but how? Let's see. Brian, there's been a lot of talk about COVID long haulers, and I'm wondering if we're seeing that, if you're seeing that at the hospital, if hospital systems are seeing that, of what you anticipate the impact of that might be on community hospitals and healthcare systems.
Well, I don't have a lot of data about that personally. I don't think most of them are going to end up in an acute care facility, hopefully, with long haul symptoms. I've certainly been talking to some folks about this issue. I have one colleague in particular who has long-term COVID symptoms, and it sounds like it's a pretty significant issue for that person. But I don't know what the numbers look like. I wonder if Dr. Rutherford has more data around it. I think, though, that when you consider the long-term effects of COVID-19 on our community, there's going to be a lot of long-term stuff, not just from these specific symptoms related to the virus, but also somewhat of a post-traumatic stress for people having dealt with this for so long. I mean, this has been a huge deal for individuals and families, financially, emotionally. I think we're going to see issues with substance use disorder, alcoholism, depression. And then the long-term financial impact is going to create health problems just by itself. So I think that we're all going to be seeing that for a long time. Certainly here at the hospital, absolutely at the urgent cares. I think that we should get ready for that.
Roger, can I add something to that?
Yeah, please.
The conversations that we've been having with Operation Warp Speed have actually been on the therapeutics side, around an infusion therapy that they're working on, and can that be administered in urgent care? So I think they are looking at this, not necessarily long haul as you're talking about, but this is not going away for a long time. And they're really looking for, do they put these in dialysis centers? Do they put them in urgent care? What do those look like, depending on how things, what the EUAs look like and what the criteria for that are. But we've got an outreach from them a couple of weeks ago. So we're definitely on that radar. So that could actually be a kind of an interesting play for urgent care, depending.
Right. If we did infusion of monoclonal antibodies or convalescent plasma, is that what you're talking about?
This is where I wish I had a College of Urgent Care Medicine guy sitting next to me.
Oh,
so
okay. Yeah.
It would be for,
I got it.
Yeah.
George, go ahead, please.
I said it would be for monoclonals because you have to be big sick in the hospital for convalescent plasma. I was also going to add to Brian's list of things that have gotten worse. One thing that hasn't gotten worse, sexually transmitted disease rates are down, way down, which I attribute to the bars being closed. So
right.
And as
there's a lot of talk. Yeah. There's a lot of talk about what's going to happen with when flu season. It's actually officially underway, and flu and COVID. The experience in the Southern Hemisphere has been that flu season was fairly light. But on the other hand, Australia, I think, had more people vaccinated than ever in history. So for the flu, but I'm wondering what your thoughts on that are.
The flu season in Australia after March was non-existent, and that was a similar experience in Chile and Argentina and South Africa. So, and it gets racked up to masking. The strains aren't changing much this year. The vaccine's about the same. And I think we could, while it's a good point of to get people vaccinated and to be prepared and to try and keep them out of the EDs, it's not that the experience in the Southern Hemisphere wasn't bad at all. The other thing is we're just doing a big review of flu and COVID co-infection, and it's curiosity stuff. It doesn't happen that often.
Doesn't happen that often. Mm-hmm. Okay. Well, I think we're about running out of time. So if this were a presidential debate, it would be time for closing statements. Let's see, Llewellyn, what do you see as you mentioned some of the things you see as opportunities for urgent care in the future, and maybe you could just, mention a couple things real quickly, like the infusion possibly of monoclonal antibodies.
Yeah, I think the things that I would probably highlight, is the infusion opportunity, which to me is kind of interesting. Particularly, now I'm going to sound like I know what I'm talking about, particularly when we move off the RNA based into whatever the other kind is, they can get that infusion time down to 30 minutes. And so it makes it, something that's more attractive to urgent care than a 4-hour visit. So I think that is pretty interesting. I think the interweaving of telemedicine into that really full continuum of care that we'll be able to provide, where we can participate in both those camps, as opposed to being threatened by telemedicine, I think is a big opportunity. And then I think that the things that Brian was talking about earlier, that has given us an opportunity to look in, this has been an absolute test of our operational efficiencies and abilities, and exposed a lot of, could we have been doing a better job of infection control overall? Probably. I mean, I think people are really realizing that, and looking at the way that they have their workflows designed and the way that they have their roles designed. Urgent care is, and we're seeing this on the association, the parallels are really interesting. We are firefighters. That's what we do all day long. And that's probably not really the best way to run a medical center. And so I think it's really helped us focus on, or see the opportunity in refocusing on consistency across how we do what we do. I think that's a big opportunity for us as well.
And Brian, what about how do you see the pandemic shaping the future of community hospitals?
Well, I mean, we talked about the financial stuff, and I would just reiterate the fact that we have to be more data driven in the future. We've got to be more nimble. We've got to be able to fix some of the operational problems that we've had. I think if you look backwards, it's pretty clear we weren't prepared for this very well at a local hospital level, at a division level, at a healthcare system level, and certainly not at a national government level. I think that there was a lack of preparation, and then the way it's been handled since the onset has not been helpful. I would say that this has been generally a very negative thing, but we cannot ignore the fact that there is a silver lining here, and we would be borderline criminal to ignore the fact that we need to work together more effectively, and there's an opportunity for that to happen. The hospital, working with the community, working with physician partners, working with the urgent cares. So we have to keep that going, I think, forever, basically. And so we can't just go backwards to the way it used to be for us. So let's look at this as an opportunity as well as the challenge that it's been.
Right. And George, boy, there's so many more questions I would love to ask you. Like, the pandemic has sort of revealed, in my opinion, the weakness of a healthcare system that's where one's coverage is based on employment, with so many people unemployed.
Yeah.
That's something that we had chatted about a little bit ahead of time. And I don't know if you want to comment on that, or just how you see the pandemic shaping the future of our healthcare system and of public health. And
well, I think public health is going to be, we're going to devote substantial resources to picking up the next one of these. There are 4 more beta coronaviruses in bats in Southeastern Asia that are just waiting to cross over, just to tell you the good news. So what I would encourage all of you to do is to get to know your local health officers. You guys are living in, I assume you're sort of, a lot of you are kind of like in the Sierra foothills and stuff. I mean, maybe that's just who's talking. But
it's just me, I think.
there are a lot of weird diseases in California, where there's enzootic plague, there's hantavirus on the eastern slope of the Sierra, there's typhus in the parks in Los Angeles. Okay, just so we're all clear on this point. There's relapsing fever. There's all sorts of weird stuff. So get to know your health officer, and please report diseases as they come down. For us in public health, a lot of this involves the interface with veterinary medicine. So we're very tight with Davis, and are hoping to get all the surveillance systems set up, which, oh, by the way, were taken down in October, including one that was based in Wuhan specifically to look for this kind of stuff. So talk about a colossal failure. I mean, that epitomizes this as much as anything. That sort of surveillance, that's kind of way out in the front end surveillance, is really important, not only for weird diseases like this, but also for the next influenza, the next inevitable influenza reassortment and transmission events.
Well, thank you very much. I hope this has been an informative panel. I've certainly learned a lot. And thank you, Dr. George Rutherford, Dr. Brian Evans, and Llewellyn Horwitz, CEO of the Urgent Care Association.
Thank you.
We will now adjourn this CME portion of our program.
There we go. Small technical challenge to start. So I'm Steve Schumann, and I appreciate your spending time with us this morning as we talk about the occupational medicine implications of COVID infection and how that impacts our practices and our patients and others involved. I started off I completed an emergency medicine residency a number of years ago, practiced that for a number of years, and then migrated to occupational medicine, which I did for about 30 years, and then moved to Salinas, California, joined Doctors on Duty, and for the last 13 years have been practicing urgent care medicine in the Monterey Bay Area. One of our presenters, Martha Camacho, who's, there we go. You can read her bio, but Martha's Vice President of Human Resources at Scaroni Family of Companies. One of the companies among the group is Fresh Harvest, which Martha may correct me, but has approximately 4,500 H-2A farm workers and other employees in a number of Western states and Southwestern states. It's a very large company providing harvesting services. And I've appreciated working with this company. I found that it's incredibly has an incredibly enlightened attitude towards support of their farm workers, the field workers that they employ, and it's been a pleasure to work with. The next presenter is Raj Das. Dr. Das is Medical Director of Risk Management for California Albertsons, Safeway, and Bonds. His focus is 45,000 employees among those stores in the area of risk management. He's got long service in healthcare as a treater and in administrative activities as well. The next presenter is Marco Lucido. Marco is an attorney in Monterey, California, associate at Fenton and Keller, a firm of more than 65 years duration, and has extensive experience in labor and employment law, general business litigation, and workers' compensation, working on the defense side. And then finally, Paul Gendron, Dr. Pastor Paul, founder and CEO of Workforce Chaplaincy, an interesting organization, employs 5 bilingual chaplains and serves 12 companies primarily in California, whose employees include 6,000 agricultural employees and approximately 3,000 other employees. And these are companies whose owners have particular concern for mental as well as physical health of their employees, take a proactive step in trying to assure that. And Paul's group works in counseling and support of employees, not just in the work comp arena, but personal as well, and has been a blessing, I think, to a number of those companies. What I'd like to do is just share some thoughts about what we're doing here today. Why are we talking about workers' compensation? Well, and occupational health. One thing is, many of us in urgent care medicine are doing occupational medicine. It's a large piece of business for many of us, and COVID-19 has significantly affected our practice in doing that work. And it's created some particular challenges. One thing about urgent care, about occupational medicine work comp, is that it's a complex field. In the urgent care, we just tend to deal primarily with patients, healthcare providers and patients. But in occupational medicine, urgent care, we have to deal also with other players. There are employers who are involved, work comp carriers, there are ancillary providers, there are attorneys sometimes involved, and others. And so COVID-19 has affected not only our interaction with our patients, but it's affected how we work with these other folks. So if insurance carriers, adjusters are working from home, and we can't get a hold of them to get authorization. That can be a challenge. When we're trying to get authorization for studies, procedures that we want to do, if we can't reach the specialist to give us authorization, that's a problem. And there are others. So, and it affects physical therapy, the chiropractors we work with, and others as well. So, COVID-19 has been a particular challenge in the area of occupational medicine and work comp. Then the other aspect of it is that we have particular responsibilities as OCMED providers to make determinations about causation, for example. Is something job related or not? Is this COVID, this coronavirus infection in a particular patient job related? Well, we've got some recent help this year from California governor's executive order and some legislation that we'll talk about in the course of the morning that have given us some assistance in determining what's job related. But absent that kind of legislative or executive advice, it can be challenging sometimes to determine causation for a particular patient's infection. We have to make decisions about treatment. We use the medical treatment utilization schedule in California. And then we make decisions also about when patients are maximally improved, when do we conclude care for a particular situation, and then have to make decisions when there's a permanent problem about impairment and about disability. And it's become particularly challenging to make decisions in those areas because of the COVID epidemic. So this infection, this pandemic has influenced us in a variety of ways, and as we do occupational medicine and urgent care. And what we want to talk about in the next hour is what some of those issues are, how folks on the panel are dealing with those, and how can we practice as effectively as possible doing urgent care and occupational medicine. So let me start off with Raj. I wonder, Raj, at your stores and with your 85,000 employees, what's been the impact there on operations among your stores and among your employees? I think are you muted? It looks like you're muted. There you go.
Now, can you hear me okay?
Yes.
So it's actually been very significant. I think as we've seen everywhere else, when you visit the stores, this communication has been particularly a concern in order to ensure the safety of employees, wiping down items. If there is a COVID exposure, going through kind of a level 3 cleaning where they really scrub and, take care of every surface. In the distribution centers, when there was an episodes of COVID-19, it required a quick response in terms of cleaning and disinfecting everything. So it's been a challenge, particularly with reporting, from the HR perspective, contact tracing. So it's had a significant impact on the store operations and distribution. Does that answer?
Yeah. And Paul, what you've been dealing with families, with employees, employment situations, and the effects of COVID-19 have extended themselves beyond just the workplace to employees at home and affected their families. And conversely, sometimes families independent of the employee have contracted the infection, and that can sometimes affect the employee. What have you observed, and what sorts of steps have you taken in the counseling process or the support process dealing with some of these things?
Well, we've had a whole range of different experiences. I mean, as from the very extreme end of an employee passing away from COVID-19, and that greatly affecting his family, of course, and then also his colleagues, to the experience of employees who see working from home as a welcomed opportunity, and they've adjusted extremely well. One of the things that is normal over the years, not during the pandemic is just working personally with employees. Already, you know, they're faced with different economic challenges, different stresses that come up. And, you know, it's an interesting time to have this conference, Dr. Schumann, because I usually call this the playoffs for the time that chaplains work, because as we enter, especially the holiday season, we see more challenges for mental health because it brings up different financial struggles. It just accentuates that as people think about the costs that may be involved with celebrating, purchasing gifts for Christmas. So those are garden variety things, in addition to sometimes just the relationship struggles that also come up around the holiday timeframe. But now, during COVID, these things have been accentuated. And so we certainly are trying to be proactive in some of the companies where, and I know we'll be talking about this quite a bit more with those related to human resources, but trying to keep employees safe and giving them the tools and the resources they can to feel safe if they are working daily at a workplace. And so, of course, things have changed over time. Early on during the pandemic, there was a lot of anxiety, a lot of fear of the unknown. And now during the course of time, since March, largely people that are on site in industrial settings, maybe in a production environment, they feel more secure. And so our focus as chaplains has been certainly to support those who have been infected by the virus and maybe hospitalized. In fact, this morning, I've been communicating with one woman that had a 1-month hospitalization and she's still off from work. And I know we'll talk about some of those things later.
Right. And Martha, let me ask you about how you've managed, as we turn to operational discussion, farm workers living and working in close proximity. You've got folks out in the field or they're still in the field, but working shoulder to shoulder, cutting and packing. You've got farm workers living in close proximity in living facilities of various sorts. What's, you and I talked a little bit before about this. What's been your experience in managing those particular challenges, trying to separate folks and then watching for onset of infection, COVID, and then trying to deal with it? Big question.
Good morning. So one of the first things that we did right in the beginning was just take our experience with food safety and start learning, you know, we were fortunate to already be cleaning off our machinery and disinfecting the areas of the housing. We just took it up a notch and we started doing more disinfecting. The difficulty in the beginning was really the fear and calming people and making sure that they felt safe at work. We were able to start putting in separations on our harvesting machines. We were the first ones kind of going out there and putting a plastic separation between one harvester and another harvester, which helped us, one, to calm the fears, and two, to be able to provide for our consumer that there is a separation. If anybody was symptomatic, they immediately reported it. We had an immediate reporting system. We call it our internal system, where a foreman would notify if the person was feeling any slight symptom, we wanted to know so that HR could be able to go back and counsel with that person and understand what was going on with their medical situation. We were facing people that it was before you would say, well, if you have a slight cold, it's okay to come to work. Now we had to tell them, stay home. Everybody stay home. Don't come to work with any slight symptom. So it was a bit of a challenge. Also because we have we utilize an H-2A program to bring in supplemental labor from outside of the country. They do not have their own personal housing here. So immediately we knew we needed to develop separate housing. All of these programs had to be voluntary. They had to decide to use the housing. So it also took another component of making sure that the employee understood they weren't forced to use the housing, but we also didn't want them to go home and spread the virus if they were positive or even if they were symptomatic. So it took a lot of discussion, a lot more than HR was accustomed to, because normally HR separates any medical issues from the foreman or from anyone. So it was very interesting in the beginning, but we're very fortunate to be able to counsel and teach our farm worker population the difference between onset of a symptom to make sure that they shared it with us. We did have to go into getting more living quarters. So when we had people that were less than 6 feet, we had to separate 6 feet for everyone, because nobody wants to wear a face covering to sleep. We had to have people change sleeping arrangements to make sure that they were distanced. So it took a lot of personal responsibility. What made us very successful was that each of our employees took that personal responsibility to be part of the solution in our company.
Just to, you might make a comment with housing, those for whom you provide housing, I believe you use hotels and motels and other available facilities and have 4 or 5, some such number of employees living closely together. And there certainly were challenges in that kind of a situation with that number of men or women in a room.
Right. The company had to take on a personal decision to take on the cost of spreading them out. So when the requirement for the regulation says they could have been closer, we ended up distributing them. So our costs really doubled, but it was important to the ownership and the executive team that the safety of our employees is first and foremost.
And I think you've done a great job in frankly managing that. Thank you. Marco, let me ask you, what have you observed just from a legal standpoint, the effect of COVID-19 on the work you do? And I'm wondering also what sort of litigation issues, we'll get down to some specific legislation a little bit later, but just kind of in general, are you seeing increased litigation or folks requiring legal services decreased? And I know from your website that your attorneys and staff are available to see people in person if they want to be doing that. What's been your observation about this scenario?
So I've seen a huge change where...
I'm sorry, Martha, I was thinking to Marco here. To Marco,
thank you.
Yeah. Oh, unable to unmute. There we go. Now you're good, Marco.
Okay. Yeah, sorry about that. I would say from a legal perspective, to me, it's with COVID-19, it's the number of new laws and the frequency of guidance updates. And I'll just provide an example is can you hear me?
I'm sorry, I had a momentary conference, sorry.
No,
go ahead, but I can hear you well.
So, just the number of new laws and the frequency of guidance updates, it's hard because employers are focused on a lot of other things, like some of the stuff the other panelist members just went over. But I'll just give you, a small example is back in April, the federal government passed the Federal Coronavirus Sick Leave Act, and that under that act, employers must pay for paid sick leave and paid extended FMLA leave. And specific to healthcare providers, there was an exemption for employees that were healthcare providers. The problem was, under the law, the definition of healthcare provider was extremely narrow. A few weeks later, when the Department of Labor issued their regulations, it had an extremely broad definition, basically saying all employees of healthcare providers are exempt from the federal sick leave requirements. So at that point, for months, the advice to healthcare clients was none of your employees are subject to this federal sick leave act. Fast forward 5 or 6 months later, there's this Southern District of New York case that essentially disagreed with the Department of Labor and invalidated those regulations, after which the DOL amended their regulations, and now there's somewhat of a more limited definition where the advice to healthcare employers now is, well, it depends. Some of your employees are subject to the FFCRA, some are not. And it really depends on whether the employee is providing direct patient care. So for instance, a hospital might have an IT assistant or a receptionist, and those employees are going to be entitled to the federal sick leave law. But other people such as nurses, nurse assistants, the hospital can essentially say, you can stay home if you have COVID, but you're not entitled to these sick leave benefits under federal law. So just, you know, with everything else going on, the confusion with some of the regulations and the way the written law is written and changed has just provided some additional confusion to employers.
All right. And shortly we'll come to some California legislation. Let me continue on the operational, from the operational standpoint. With a significant amount of working from home, I'm wondering if the definition of job-related conditions or what constitutes job-related conditions, such as repetitive strain, workstation ergonomics, trip and fall that are unwitnessed, or other issues. I'm wondering to what extent that's going to prove to be a challenge. Some of these things happening at home. Raj, what are you likely to, what thoughts do you have about that? You need to unmute, Raj.
I think that's a great question, and we've dealt with this in the past, but not to this extent. And when you look at causation or work-relatedness, there are two elements. One is the medical question in terms of arising out of employment. Is there some type of activity that is responsible for the specific injury or symptom? And then the second issue is a course of employment, which is a legal term, a legal definition, and I like to turf that over to the attorneys. So breaking it down, if the individual's working at home and doing something for the employer and they have an ergonomically inappropriate setup, or they're not interacting well with the computer equipment and they develop symptoms, to me that would be arising out of employment. But then I would turf it back to Marco in terms of whether that would be a course of employment question. And I think that we've treated enough injuries that with people working from home that I don't think it's that big of a debate. I think it's a little bit more interesting if you're talking about COVID and you're talking about trip and falls during the workday when they're going to the kitchen, etc., and hazards in the home. I think that's a very interesting question. But I would say that there's no question about, from an arising issue in terms of that activity triggered the injury, the issue is whether it's a course of employment.
Marco,
Yeah, and I'll just step in and say that I think Raj is 100% correct. And, you know, in my practice, I've drafted several remote work policies, and oftentimes, we hit a lot of different issues in those policies. But one of the things that I often talk about is, the scope of employment. And so when people are at work, they normally are at work within the scope of their employment the entire time, except for rest breaks and lunch breaks, and they're free to do as they wish. But when people are working from home, sometimes they might be in their backyard exercising or doing other things, and it's extremely difficult for employers to keep track of all that. And so I think the bottom line is just that there's going to be a lot of unanswered questions when somebody gets hurt at their home when they're working remotely.
Yeah. Senate Bill 1159 gives us a little bit of help. Normally we would be thinking about prevalence, perhaps comparing prevalence of exposure in the workplace to COVID versus, and I'm thinking about etiology, compared to prevalence in the marketplace or elsewhere. And it can be a challenge deciding, continuing on what Roger's talking about, whether something's job related or not. But Senate Bill 1159 creates a work comp presumption and provides for work comp benefits to employees among specified categories when an employee contracts COVID-19 within 14 days of the last day of work for the employer. And there's much more to the bill than that. I'm not sure. That's interesting that if someone contracts COVID and they've worked in the last 14 days, then it's going to be considered a job-related problem, which again simplifies it for us. But that's an interesting thought about causation. I don't know, Raj, do you have a thought about that? Is your stores going to be hit with more COVID cases that people might have picked up in the community?
At least our experience up to this point is it's been more incident reporting and not as much work relatedness. So with the current law as we interpret it, we haven't really seen the spike in work-related COVID illnesses that you'd expect, because we have an aggressive contact tracing program that we started right from the beginning with nurses, trying to protect employees and ensure that if individuals had been affected at work and then interacted with someone, we would be proactive in terms of isolating these individuals. It really has not had the impact from a workers' comp perspective that I expected, to be honest with you. And in general, with presumption laws, you usually expect it to be very, very, all-encompassing in terms. But it hasn't, at least up until this point for us, it hasn't turned out that way. So I think with the rigid interpretation of the regulations, for our class of workers, which that are not healthcare workers or first responders, it's been following the science, and which is good, I think.
Yeah, I guess, yeah. And Paul, I'm wondering, picking up on that, do you, not so much from a diagnostic standpoint, but from a patient and family response to a family member, an employee developing COVID, I'm not sure how many of these you've seen, but I wonder if there's anxiety on the part of employees trying to determine where they may have contracted this COVID and what the response to that is, and particularly in situations where employees may feel that their employers are not giving them adequate protection. I don't know, is my question clear? Is it,
Yeah.
Folks concerned about how they might have contracted things in their response?
I would say one of the more common responses is from the spouses that may work from home or may be working in the home with children, and they're aware that maybe a spouse is exposed to lots of people, even though they're wearing face coverings. But the thought is, I've even heard some employees say the first thing that I have to do when I walk through the door is, get undressed and go get in the shower, because that's the level of anxiety that some spouses have, that their marriage partner is working in an environment with lots of exposure. And so I've had many conversations where that spouse is particularly anxious. Incidentally, this is also true working with law enforcement. Our law enforcement officers are out in the public and making entry sometimes to homes because they have to, and so their spouses also, I've heard feedback, have some level of anxiety. Are you bringing home the virus because of your exposure? So that's certainly true.
And Martha, on somewhat of a related thing, you and I have talked about this at least once, your sense that in terms of managing the problem, that in some cases that a lot of responsibility is shifted to employers, where I think that what you were saying before was it may have been preferential for government entities to take more of a leadership role. And I'm not asking a political question here, but just in terms of where the responsibility lies in managing these cases. Is too much being asked of employers in terms of trying to handle this pandemic? Or what's your sense of the employer's role in all of this?
I think the difficulty that we've experienced or that we have seen is that we don't see any real clear direction for employers. It used to be that we could anticipate, you know, the environment. Now it's really anything that's brought into our area, we're going to be responsible for. If we just based on how the law's written, it's not easy for you to understand which part are you responsible for and which part is the employee. That kind of gives the employees the interpretation that your employer is responsible, and that the way it's written, the employer has to prove that you didn't get it from their workplace. So it makes it sound as if everybody that is working is getting it from their workplace, instead of vice versa, which is what we've experienced, where we've seen it coming in from the outside, not that we have it at our workplace.
All right. Marco, let me ask you about the General Duty Clause, OSHA, in terms of the requirement that employers create, furnish to each worker employment and place of employment that are free from recognized hazards that are causing or are likely to cause death or serious physical harm. What thoughts do you have about that? How would you comment to employers what their responsibility is in terms of providing a safe workplace? You know, the CDC and others give us guidance about what we should be doing, but what's the extent of burden on employers in providing a safe workplace?
Right. So I think the first thing that's important to know is, you know, the general duty clause is it's a catch-all clause that applies when usually in a situation where there are no other OSHA violations. It allows OSHA to issue a citation in a circumstance where there are no other violations for which it can issue a citation. For me, I think there's a ton of guidance out there. There's guidance from the federal CDC, there's California guidance, even within federal and state law, there's different guidance from different agencies. It makes it extremely difficult for employers to know what they are supposed to do. From my perspective, though, I think the key for California employers is to make sure they're following the California guidance, because the California guidance is industry specific, and it's also co-published by CalUCA. So for instance, for healthcare providers, you can go to the california.covid.gov website, you click on your specific industry and you'll find the guidance that's applicable to your business. And I think from my perspective, if an employer is following all of those guidelines, they're going to be in a really good position to not be subject to a general duty citation.
Good. In terms of getting employees back to work that have been ill, Raj, what are you doing? How do you have you had many of your employees with COVID? I think you mentioned that really is more that you protected, and there may not have been a large number. What's been your experience of among the 85,000? Have you had cases of folks developing job-related COVID, coronavirus infection?
Yes, early on when individuals weren't masked, yes, there were, exposures. And then typically in the break rooms and where individuals would doff their masks and eat lunch together and those kinds of situations. And I think that those have been addressed. And those were some of the unexpected situations where we would be very diligent about wiping down things, making sure that individuals wore masks. But then when you were getting dressed for work or eating lunch in a break room, those would be the circumstances where an individual would have a work-related COVID infection. In our experience, at least in the ones that I was brought into, those are typically the scenarios when an individual developed a work-related COVID situation. So it's not that it doesn't happen; it's just that it wasn't the onslaught that I expected, because I thought the threshold would be very, very low. And
I'm sorry, go ahead.
No, that's it. That's it.
And how have you brought the employees back to work? What have you done testing, or has it been largely symptomatic?
I think that symptoms are the best moniker in terms of return to work. We're just following the CDC guidelines: 10 days if a positive test, 14 days after symptoms, at least 14 days, and 24 hours symptom-free. And I feel that those are adequately protective as long as everyone's adhering to the universal masking policy in terms of customers and employees and fellow employees adhering to wearing masks. I feel comfortable with returning to work without a negative test. And I think having a negative test return to work is sometimes problematic if someone's symptom-free, because I don't know that we have the science yet to prove that someone would be infectious at that stage. And then when you have a low prevalence, there's a higher chance of a false positive, so it just complicates things a little bit more, I think. And when you wear masks, I think it's protective.
And Martha, how are you bringing folks back based upon symptoms and time?
We're following the same CDC guidelines. It was difficult in the beginning because it was changing, but the employees are now pretty accustomed to telling them to go get a test and prove that they were free of COVID made us feel like we were sending them right into that population of the sick, getting in line behind a line of other people that were sick. So we went through, first it was the 12 days, then we went down to the 10 days and making sure that they're symptom free. With the flu season coming on board, we're starting to change our strategy to just make sure that we're being able to isolate flu from COVID just because they're similar symptoms.
Right. And let me ask you, continue, Martha, in the last discussion, there was the mention of long haulers, or also several terms that we're seeing some number of folks that have persistent symptoms. I don't know if you've had that among your employees, or several folks that I'm following, nursing staff that are having persistent symptoms now a couple of months later. And I think there's still lack of understanding of why that occurs. Have you had, and I'll ask Raj the same thing, have you had any of your workers fall into this category of chronic symptoms lasting longer than the couple of weeks we usually expect?
Well, we had a couple of them with the lingering cough. We had one with 45 days with the lingering cough. We had to come up with alternatives. We had the availability and we were able to come up with an alternative of saying he can work on his own or come in, and after we would disinfect. So we had different strategies that we would use just to make sure that we could get them back to work, but that they had an independent work site. So that helped us out a lot. We were able to separate offices for other people, bringing and separating them and moving people around to make sure that one person with the lingering cough was in an office on their own if they weren't able to work from home. We also put in a lot of strategies, buying a lot of laptops when everything was on back order, making sure that we were able to deploy a good system for working from home. And then HR changed to trying to be as supportive as possible for our work from homes, because everybody who works from home still wanted to interact with people. So we would do virtual coffee breaks and do activities with them. And we had a lot of, communications with them where we try to keep them in the loop with their teams. So different strategies.
Yeah. And Raj, have you had any of that category of patient of prolonged symptoms?
You're addressing whether they return to work or not, or is it just
the persistence of symptoms and facts such that they really haven't been able, among the symptoms, or at least the ones I see, are headache, cough, and fatigue. And I've pretty much left it to the patient to tell me, to be honest, when they feel capable of working, because we're doing this by telehealth most of the time, and it's a little bit hard to judge. You have to count on the veracity of the patient's complaints. But I'm just wondering if you've seen that category of person that seems to be falling into the category of what's been described as long haulers.
You know, it hasn't risen to my level yet in terms of what we would call delayed recovery that you see with all the other types of work-related injuries, in terms of there's a difference between what the expected recovery time is and delayed recovery. With coronavirus, I know that we've had people that are severely ill that have been in the intensive care unit, et cetera, and they've had an extended recovery time. But with respect to individuals that just, you know, young with no risk factors that seem to tend to have delayed recovery, that hasn't been an issue, but it also might be an issue in terms of the number of work-related instances, because I think that with the 2-week benefit period, it really is, I think that's addressed a lot of the work-related issues in terms of the time off and getting paid and people recover. And so I haven't, you know, I don't see it as an issue yet. I think it will be. I still think it will be, but it hasn't been elevated to me yet.
Mm-hmm. Okay, Paul, are you seeing any of that among folks that you deal with that are just really can't escape the clutches of coronavirus infection and whatever effect that's having on them and family?
Well, interestingly, to Raj's point, not really among those that were, you know, considered healthy when they became infected, but one employee I'm having quite a bit of contact who's still off from work. When she was in the hospital, she was considered borderline, you know, leaning toward diabetes type 2. And it was interesting because she joked that one of her coworkers had sent a care package that was beautiful. You know, it was filled with all these delicious candies in the midst of learning, okay, she's not going to be able to enjoy that. But she shared with me that she is being treated now following her hospitalization for diabetes, taking metformin. And her symptoms are, she's got some damage to her lungs. So even this coming week, I think she'll be meeting with a pulmonologist to assess what to do going forward. She did share anecdotally that she's also experiencing, and she said, I started reading about this because it was troubling to her. She was experiencing hair loss. And I'm curious, just from the other medical practitioners, if that's something that they're reading about or hearing about.
I have not seen that. I'm not familiar. Raj, have you have a thought on that?
No, I haven't. That's one of the few symptoms I haven't heard attributed to COVID, to be honest with you, yet. And that doesn't mean it isn't. It's just I haven't heard that.
All right. Marco, let me ask you this. I'm wondering about folks that have chronic symptoms and may have difficulty going back to their regular job or maybe any work at all. I'm just wondering, under ADA, what the impact of this might be in terms of rehiring or finding new jobs. I suppose if someone can't go back to their regular job, it's dealt with under work comp if it's presumed to have been a job-related problem. But then going forward, I just wonder, maybe it's like anything else where there's chronic disability, but I just wonder if COVID is going to produce any particularly different conditions or considerations under ADA or other prevailing legislation about work. It's sort of an open-ended question.
Right. Yeah, and the answer is it's sort of a mixed bag. So the EEOC, which is the federal agency that basically implements and analyzes the ADA, under EEOC guidance, COVID-19 itself is not a disability but COVID can, create disabilities. And also, if there is guidance that says if somebody is at high risk of COVID because of an underlying condition, that underlying condition, if it otherwise qualifies as an ADA disability, then the employee would be entitled to the protections under the ADA. From my perspective, the problem is it's an extremely confusing analysis. There are no black and white rules on this, and we're going to see how it plays out in future guidance. And so to me, it creates landmines for employers who have somebody that had COVID, stayed home for a couple weeks, and for whatever reason says they can't come back to work or asks for some sort of accommodation. The question is, is this employee entitled to a reasonable accommodation? Do we have to engage in the interactive process? And the answers to some of those questions are a little bit gray. And so I just think that creates risks for employers where you want to err on the side of talking to the employee, seeing if there's a way you can get the employee to return to work. Are there any accommodations that you can provide? If not, what's the business reason for not being able to provide those kinds of accommodations? And if you read the regulations, both under federal and state law, at the end, it always, the EEOC and the California DFEH always say, during the pandemic, it's important for employers and employees to come to common sense solutions that are practical and reasonable. So I think the key is to, just focus on what you think makes sense, try to be reasonable with employees, and err on the side of trying to accommodate them.
Okay. In the remaining 2 minutes, I'd like to ask Raj in 60 seconds or less, how are you going to handle immunizations when that eventually becomes available? Are you going to mandate that among employees? Are you going to make it optional? Are you going to, are you going to provide them in the stores? Are you going to send them off to CVS or the family doctor? You got 60 seconds, right?
I haven't been engaged in that conversation yet in terms of whether they're going to request, mandatory vaccinations. I think it would serve as a precedent. If there's no federal regulations or state regulations that requiring it, if an employer requires it. So I think that would be a precedent. My personal bias is, that it would have to require some regulation from the local public health officer to require that. I wouldn't think that the employer would initiate it, but that's my personal opinion. Mm-hmm. Hope I got it in the time frame.
Yeah. And in the 1 minute remaining, Martha, how are you going to approach recruiting your out-of-country employees? What have you learned from all of this that you're going to take forward as you do your business? What things are you going to be doing differently, do you think?
I think our biggest commitment will be to carry our COVID plans out into before recruiting, just making sure that it's just like we do drug screening, it's going to be a COVID screening, something that will be able to help the employee know and calm their fears as they come and cross the state, and making sure that we follow CDC guidelines.
Okay, now that makes sense. Paul, do you have in the last 20 seconds any additional thoughts?
My only thought would be, I know it was one of the questions you were posing was in the future, how will workplaces be prepared for future epidemics or pandemics? And I am proud, by and large, as I just observed how well companies have adapted, and bringing along employees. There are certain groups of employees tend to be maybe less educated, more skeptical of the things that become requirements to stay safe. And I think we'll be more prepared to educate throughout the organization, because increasingly we want to avoid that people are feeling like things are being done to them as opposed to them participating in being proactive. And I think that's something that we just observed took place, that both companies and employees really realized, I need to do this not just for me, you know, but for those that my coworkers and my family that I come home to. And so it's been encouraging for me to see that shift and becoming more educated. I think there's still more work to do.
Good. Okay. Well, thank you all for your time. Thank you for sharing your expertise. I really appreciate that. And I'm hopeful that what we've discussed, the information provided, is useful to those folks listening. Thank you very much. Have a great rest of the day.
Thank you.
Thank you.
Thank you. Bye.
Bye-bye.
We will now adjourn this CNE portion of our program.